Hello and welcome to my Opthal teacher. The topic for today is keratoplasty, penetrating keratoplasty to be specific. Penetrating keratoplasty, abbreviated as PK or PKP, is defined as a technique of performing full thickness corneal transplantation, as you can see in the diagrammatic representation, wherein a diseased cornea is removed and replaced with a healthy and viable donor corneal button. This is the picture of a post keratoplasty patient in the immediate post-op period. So when I say keratoplasty or corneal transplantation, we should think about two types of keratoplasty, that is full thickness or partial thickness. Now, we're going to deal with the full thickness or the penetrating keratoplasty in today's class, but one should also know about the partial thickness or the lamellar keratoplasties. Hopefully, I will upload a lecture on those as well. For now, know that lamellar keratoplasty or partial thickness keratoplasty is of two types, anterior and posterior lamellar keratoplasty. Anterior lamellar is further divided into superficial anterior lamellar and deep anterior lamellar keratoplasty, and posterior lamellar is further divided into DSEC, that is Descemet stripping automated endothelial keratoplasty, and DMEC or Descemet membrane endothelial keratoplasty. So let us concentrate on the topic for today, that is penetrating keratoplasty. Now, based on the indication, we can divide it into the following four types. Optical, which is to improve vision, such as in this case, where there is a central corneal dystrophy. It is very severe, it's impairing the vision. So this is to improve vision. Other indications include keratoconus, corneal scarring from some other cause, pseudophakic bullous keratopathy, and corneal degenerations. Tectonic. As the word suggests, tectonic means to restore the integrity. It has something to do with the integrity of the ocular surface, rather, tectonic. As in the case of desmetocele, as you can see here, you see how thinned out the cornea is. So this is an impending perforation that is an indication for a tectonic keratoplasty. Therapeutic keratoplasty, as in this case. Now, this is an infected cornea, very much infected cornea with an abscess and thick white infiltrate, probably not responding to topical antibiotics. And the last resort is doing a therapeutic PK, which is removal of the infected corneal tissue. And some people also get a keratoplasty done for cosmesis, that is to improve the appearance. There is this another classification, which is according to the prognosis of the different, situations in which the PKP is done. So it's divided into four categories, 1, 2, 3, 4. Category 1, it has excellent prognosis and more than 90% success rate. The ones that I've highlighted in yellow are the important ones that you should remember. So keratoconus, corneal dystrophy, and stromal dystrophies to be particular, and Fuchs dystrophy early stages. These three have excellent prognosis and more than 90% success rates. Keratoconus is also one of the most common indications of penetrating keratoplasty. The second category is 80 to 90% success rate and includes pseudophakic or aphakic bullous keratopathy, Fuchs dystrophy, advanced stages, and herpetic keratitis. Category 3, 50 to 80% success rate. This includes active keratitis, so that would be a therapeutic keratoplasty, corneal perforation, tectonic keratoplasty, corneal opacity in children. And category 4 or less than 50% success rate are these ocular surface diseases like ocular pemphigoid, Stevens-Johnson syndrome, history of multiple graft failures, neuroparalytic neurotrophic keratitis. Now, of these, the first, second, and the last two conditions are the ones that are going to probably persist despite the PK. That is why the poor prognosis and the poor success rate. So that is another classification. So let us talk about the preoperative preparation of the patient. So you have to take a thorough history of the patient, of your patient. You have to ask about any history, previous history of redness, episodes of pain, redness in the eye, indicative of infection, any history of surgery, any retinal diseases, like for example, diabetic retinopathy, the duration, how long the corneal opacity has been there, was there any ocular injury? You have to then consider maybe posterior segment problems, collagen vascular disease, which will have an implication on the prognosis. Again, history of herpetic keratitis, same thing. And it's an implication on the prognosis, and systemic comorbidities such as diabetes, which is also going to affect your post-operative healing period. The next thing is ocular examination. So you take a proper visual acuity of the patient, preoperative visual acuity by a Snellen's chart. Sometimes the person may not be able to, the opacity or the pathology in the cornea would be so severe that the vision may be reduced to hand movement or even perception of light. In this case, you have to do a proper projection of rays for the patient. You can use a stenopic slit to see how much improvement is possible, again, to prognosticate. And in case of children, you can do an occlusion, preferential looking test, and Cardiff visual acuities because they are non-verbal. Do a good refraction also. Then on the slit lamp, what do you look at? You have to rule out any adnexal disease, that is any, dacryocystitis, any sty, blepharitis, any signs of infection. If so, you have to wait, give antibiotics, treat accordingly, and then once the active infection is not there anymore, you do the PK. Then opacity. Now, for example, in this case, you describe the opacity, you document. We've already talked about corneal documentation in one of my previous lectures. So you document the opacity properly. It's a scar, so you'll be representing it in black. And you'll say that this is a circular scar about, say, 5 mm in diameter, involving the central cornea. And you can take us in the slit image, you can actually see what is the depth of the scar. So this is probably involving more than 50% of the stroma. It is a leukomatous grade corneal opacity, and there may or may not be vascularization, and you have to comment on the corneal sensation. So that is how you describe it preoperatively. Look at the anterior chamber, look at the depth of the anterior chamber, see if there are any anterior synechiae. Now, the cases that have anterior synechia have a slightly different approach, surgical approach. These synechia have to be broken, and you have to know that there is a synechia over there, because when you are dissecting off the, recipient cornea, before putting the donor cornea, you have to be careful that there is a synechia, because it will obviously make dissection slightly difficult at that particular site. So you have to know about pre-existing anterior synechia. Then pupil, you have to know whether the pupil is dilating or not. And a preoperative dilated pupil often results in a Uritz-Zavalia syndrome, which we'll be talking about later. You have to see if there are posterior synechia. Now, any presence of synechia would make the surgery also challenging, and they also have an implication on the recovery and the prognosis of the case. Then know about the status of the lens, phakic, aphakic, or pseudophakic, and plan accordingly. If the patient is aphakic, you may want to implant an intraocular lens in the same sitting. You may have to do a combined procedure, and so on and so forth. Posterior segment. Now suppose there was a history of trauma, and then there is an opacity over there, and you cannot really see the fundus properly. You have to evaluate the posterior segment using a B scan in such cases. Intraocular pressure. Now in cases of corneal scarring, as we know, applanation will not be very helpful. It's going to give false readings because the cornea may be overly thick or overly thin. So it is preferable to use non-contact methods, and if they are not available, one can even do a digital, tonometry. Dry eye workup uh, is desirable, not, absolutely mandatory. Keratometry, yes, keratometry is a must if IOL implantation is planned. And if the keratometry is unreliable, again, because of the scar, you may not be able to see the Myers properly, then in that case, you can do the IOL power of the other eye, or you can just input the standard K values into the machine and use them for calculating the IOL power. And ASOCT, again, desirable, and ASOCT is usually more, needed in places where they're doing lamellar keratoplasties. So as to decide whether you're going to do a full thickness graft or a lamellar graft, right? So this is a picture of an ASOCT where you can, the scar appears hyper reflective. The corneal scar appears hyper reflective in an ASOCT. So you see the scar is involving the mid stroma and parts of posterior stroma. So you have to accordingly decide what level at you have to do the keratoplasty. You see there's some thickening of the cornea also over here. So yes, OCT is useful in those situations. So storage and preparation. A little bit about tissue storage and preparation you can also find when you read a chapter on eye banking. They have, they have a much more detailed explanation of how to obtain the you know, donor button from the deceased person and how to store it in the short term, long term. All of that comes under iBanking. So that would be a separate lecture. You can also find another presentation, a chapter on iBanking where you can find about you can read up tissue storage and preparation in much more details. Now, in today's class, I've not elaborated too much on tissue storage and preparation because it's a class on penetrating keratoplasty. So, when we talk about tissue storage, the death to enucleation time, that is the ideal time for harvesting the cornea, is 6 hours. For optical PK, the tissue is to be used in 48 hours. Now, optical PK means that you're using the um, donor button for optical purposes, that is for clarity, for vision. So it has to be of the best quality, better than a therapeutic or a tectonic keratoplasty for that matter. So optical PK, the quality of the tissue, of the donor tissue, has to be very good. Then some storage media, moist chamber, which can keep the cornea, the donated cornea viable for about 48 hours. MK media, which can keep for 4 days. Cornisol, 7 days. Organ culture, 35 days. And then the cryopreservation, which can keep the cornea viable for up to a year. Now, when we are talking of the cornea, of the corneal button, uh, I keep on saying the word button because that is the terminology that you use when you go to a deceased person to, extract the cornea. You either enucleate, which was usually done previously. Now, mostly what they do is they just take out the cornea and a little bit of scleral rim and they keep it in the moist chamber and bring it to the, um, you know, bring it back in order to be transplanted. So that term I'm using repeatedly, that is basically the corneal button or the corneoscleral button, right? So that is what I'm talking about over here, the tissue storage, that is the storage of the that corneoscleral button, and preoperative tissue evaluation is evaluation of the button again. So you have to examine the epithelium, stroma, descemet folds, endothelium, and you have to do a specular count. Now, there is a separate machine available for doing specular microscopy in cases or specular microscopy of the donor button. It is separate, it is different from the specular microscopy that we use routinely in our clinic. So, for an optical grade corneal button, the epithelial defects should be less than 50%. There should be no edema. There should be no DM folds. And the endothelium should not have any guttae. And the count of the endothelial cell count should be more than 2000 cells per millimeter square. Please remember this at least. The qualifications that are, required for an optical grade penetrating keratoplasty. How the qualifications of the donor tissue for an optical grade penetrating keratoplasty. For a therapeutic grade, even a moderate haze would do, because therapeutic you're doing a therapeutic keratoplasty to remove the infected tissue. You're not really concerned that much about the vision. So even a moderate haze would do. Mild to moderate edema and mild to moderate DM folds would do. Endothelial count, even if less than 2000, say 1500 to 2000, is also fine. And the third type, that is not suitable for surgery. If it is very hazy, the epithelium haze is very severe, the edema is very severe, Very severe DM folds, discarded, used for academic purposes or research purposes, not used for transplantation to a living person. Also, if the specular count is less than 1500. So at least try to remember the qualifications for being used for an optical PK. Some contraindications. Now, when I say contraindications, when you read in the eye bank, you will find that there are some contraindications of the eye donation, of procuring the donor button and transplanting it. So those contraindications are different, and these are the contraindications in case of the host. Now, why would you not want to uh, put a new cornea on the on your patient? Why? In the following cases: severe dry eye, Steven-Johnson syndrome, toxic epidermal necrolysis, and advanced ocular surface disease. Why? Because even if you transplant the cornea in such cases, there's going to be an increased risk of rejection in these cases because this disease is going to recur again and again. First, the second group of contraindications is when there is an active infection. So with that is quite obvious. Blepharitis, basically you have to treat any of these infective conditions first, and then of course you can proceed. Corneal vascularization more than 2 quadrants again increases the risk of rejection and would be a relative contraindication. Even if you do a PK, the success rate is likely to be lower than expected. Now, this is the second group of contraindications. These are the contraindications of corneal donation in general. That is, when you do not use that donor, the corneoscleral button or the donor button to transplant into a living person. These contraindications include death due to unknown cause. If the deceased person died from an unknown cause, you cannot take their cornea to transplant. If they died of rabies, these prion diseases, so-called HIV/AIDS, septicemia, and the last three are more of relative contraindications: systemic infections, the active ones like syphilis, active hepatitis B and C, CMV, EBV, both of which are viruses, intraocular tumors, leukemia, and lymphoma. So these are the contraindications when we're talking about the donor button. So that basically is showing you the gist of penetrating keratoplasty. So you see the epithelium, stroma, and endothelium, all the three. That is the full thickness of the cornea is transplanted. This is what it looks like. This is the pre and the post transplant picture. So the steps. Now, please be with me. We will sequentially go through all of these. So the first picture over here, Flerenga ring. Now, basically, Flerenga ring is sutured to the sclera in 4 quadrants. This Flerenga ring is to stabilize the globe, and it is preferably used in case of children penetrating keratoplasty. So that's your Flerenga ring over there. You may or may not use it. The first step then is measuring the recipient cornea for appropriate trephination. So this is a caliper. The surgeon measures the diameter of the cornea, and accordingly, the donor button or the donor, corneoscleral button is cut using a trephine. So this is a trephine. So you have to measure the recipient cornea, and then you have to take the graft accordingly. Now, when you are trephining the donor cornea, remember the graft size is about 0.25 to 0.5 mm larger than the host. So if this is, say, 8 mm, the donor cornea should be around 8.5 mm in size. Then the site port, once the diameter is measured, the side port is created and viscoelastic material is injected. You have to you have to deepen the anterior chamber. The donor cornea, as we have discussed, it is prepared and cut with trephine. So suppose for an 8 mm cornea, you have taken a button size of 8.5 mm. You have inflated the anterior chamber with viscoelastic. Next, what you do is, now this button has been created and it has been carefully placed aside. Now, the recipient cornea is being partially cut with a trephine. Okay, partially cut so as to avoid damaging the underlying intraocular structures. So, partial trephination of the recipient cornea. After the partial trephination, it is lifted from one side and the castrovisocorneal scissors are used to complete the dissection all around. So this is where you have to take care of any anterior or posterior synechia that may be present, and you have to take care of avoiding damage to the underlying structures such as the lens capsule, iris, so on. Then coming on to the donor cornea, now this is aligned like this with the rim, the recipient scleral rim, corneal rim, I'm sorry. It is aligned and the first suture is placed at 12 o'clock. We will be talking about the suturing in detail. So remember, the first suture, that is the one of the cardinal sutures, is placed at 12 o'clock. What are you using for suturing? You're using 10-0 nylon sutures. The second suture is placed opposite the first one. We always, if you're doing an interrupted technique, we always place sutures at opposite ends subsequently. This helps to reduce the astigmatism. So the second suture is placed opposite the first one. That is, it is at 6 o'clock. Now, the position of this 6 o'clock suture is the most important thing that determines your post-operative astigmatism. You cannot make it very tight. You cannot make it very loose. Okay, and then you place the subsequent sutures. So 4 cardinal sutures. The subsequent sutures are placed at 9 and 3 o'clock respectively. I hope you have understood. And then sutures are placed diagonally in between the 4 cardinal sutures. Before the final 2 sutures are placed, the anterior chamber is irrigated. Remember, you had filled viscoelastic material, so you have to irrigate. Seal the side port. Final sutures placed, knots are buried, and the loose sutures are replaced where necessary. When you're burying the knot, it is advisable to bury it on the donor side. So that is the procedure of penetrating keratoplasty in a nutshell. Now, this procedure may or may not be combined with the cataract extraction, with synecholysis, vitrectomy, and so on and so forth. So, just some actual pictures, intraoperative pictures of the PK being done. So this is the trephine, and they are doing a partial trephination of the recipient cornea or the diseased cornea over here. Okay. We do not see any scar, so this may be a case of keratoconus, maybe. So several types of trephines are used. We can have disposable ones, and we are also now using excimer laser and femto laser for partial trephining of the cornea. So partial thickness trephination is done. Then a pair of castroviso scissors are taken, and the whole, whole of the diseased cornea is removed in this way, right? The whole cornea, the diseased cornea is removed, and what you see here, you see that there is, this is probably aphakic, right? And that is your open sky procedure for you, because you have removed the cornea, so you've removed the barrier to the intraocular contents. That's why it's known as an open sky technique. Next, the button that we had created, we take it from the Teflon block that was put aside, and we check the epithelial and the endothelial side, and then we place it on the recipient bed like this. It looks like this. Then the first suture is placed at 12 o'clock, the second at 6 o'clock, so 9, 3 o'clock, and other sutures. So this is a technique. This is the interrupted suture technique. Okay. I will also show you the continuous suture technique. So you see how many sutures are being used, right? So imagine the astigmatism that these sutures induce. We know that when we do SICS and say, or ECCE rather, and ICCE, we talked about those surgeries in earlier lectures. We saw how much astigmatism these surgeries were inducing. And look at the number of sutures here in penetrating keratoplasty. So the astigmatism is of the range of 3 to 7 diopters. There is a lot of endothelial decompensation, of course, because the corneal button that you have made and kept aside, that is not it's in an artificial medium. It is not receiving nourishment from the aqueous, right? It is from a deceased person. So the endothelium is bound to get decompensated a little bit. That is why we're doing a specular count and everything before implanting that button onto the recipient bed. So some degree of endothelial compensation will happen. And prolonged wound healing, of course, because so many sutures are being put over here. It has to undergo, this is the corneal button, the endothelium is decompensated. The epithelium may also be, you know, um, absent in places. So healing involves of growth of the epithelium and proper integration of this button into the recipient bed. And that takes a lot of time. That takes, months to years. Okay. So that's that. And this is the continuous suture technique, right? We just saw the interrupted sutures, and this is the continuous suture technique. So, suturing techniques, interrupted sutures are recommended in children and infants and highly vascularized corneas and therapeutic keratoplasty. The advantage of interrupted sutures is that you can selectively remove the suture if you are finding that there is too much of astigmatism being caused or if a suture is loose or infected. It appears to give a greater tensile strength overall because if one of the sutures breaks, you still have all the other sutures to hold the graft in place, and it is less likely to constrict the blood flow. The blood flow of the cornea is received from the periphery, as we already know. So, interrupted sutures are less likely to strangulate the graft. Continuous sutures, on the other hand, they are faster. They can create a tighter seal, but none of the advantages of interrupted sutures would be seen. Now, when you are suturing, look at this picture. This is the donor tissue and this is the host tissue. So the needle should pass just above the descemet membrane, that is around 90% thickness. This is the outside, this is the anterior chamber. So you see 90% thickness of the cornea, the suture bite is taken. Why do we not take a full thickness suture in this way? Because in that case, we are causing damage to the endothelium and aqueous can leak post-operatively through this tract that we are creating. And also it might serve as a source of infection because the aqueous would be in continuity with the atmosphere. Then the suture length, it should be 2 mm on the host or the recipient side and 1 mm on the donor side. So 1 mm here and 2 mm here, or you can say 1 mm on the cornea, 2 mm on the sclera. The suture knots are buried on the corneal side. This prevents vascularization. If you bury it here, it's going to cause more vascularization. So preferably buried on the corneal side. That is some of the principles one has to keep in mind while suturing. Coming on to the postoperative care, topical steroids are given intensively for the first 2 days, then tapered to 6 times for the first 2 weeks, and then they are tapered 4, 3, 2, 1 every month over the next 3 months. So steroids have to be continued for several months. IV steroids can be given 1 gram twice daily for the first 3 days. Now, why are we giving such a high dose of steroids? To prevent graft rejection. Oral steroids are also given in a tapering regimen of 40, 30, 20 mg for 3 to 5 days each, or you can give them in the dose of 1 mg per kg per day. Then antibiotics to prevent superadded bacterial infection given 5 to 6 times for 2 weeks or maybe longer. Anti-glaucoma medications, especially in cases where there is secondary glaucoma, pre-existing glaucoma, if you're doing a combined procedure such as added vitrectomy, synecholysis, and the drug dorzolamide is avoided because dorzolamide causes endothelial decompensation. Cycloplegics are used to reduce the pain due to the ciliary spasm that is there. And be very cautious about Ureth-Zavalia syndrome. And it is often seen in patients in whom you give atropine at the end of the keratoplasty. So you might have a fixed dilated pupil postoperatively with pupillary block and raised IOP. So that is what is Ureth-Zavalia syndrome, albeit very rare. Lubricants, you give topical preservative-free lubricants because you've put so many sutures, they're bound to cause foreign body sensation. Removal of sutures is only after the graft host junction has healed. That is at least 12 to 18 months or even longer. Coming on to the complications, they are broadly divided into intraoperative and postoperative complications. So intraoperative complications, so when you are making the donor button, when you're refining it, you might end up doing an eccentric or an irregular trephination. You might mistake the host button and you might confuse between the host and the corneal button. Then iridodialysis while doing the partial trephination of the recipient cornea. Corneal button damage when you are obtaining the button from the donor cornea. You have to handle the button very carefully. You have to avoid damaging it. You have to place it nicely on a Teflon block and keep it aside with the endothelial side up. You are also refining it with the endothelial side up. Then remember which one is the epithelial and the endothelial side to prevent inversion of the graft. That can happen. Then severe bleeding, like possible in any intraoperative procedure. Retain desmet membrane. Now, this happens when you are doing the partial trephination. So desmet is a transparent structure. So when you're doing a partial trephination, you might have a chance that you have dissected off the stroma and the desmet remains there because it is transparent and it remains there. It sticks to the surface of the iris, and later on, if that is left, it's going to it's going to form a false anterior chamber and lead to graft rejection. Iris lens diaphragm injury, again, during the partial trephination, you can damage some of the intraocular structures unless you are careful. So iris lens diaphragm injury, lens expulsion, vitreous prolapse. Why lens expulsion and vitreous prolapse? Because now the barrier, the cornea that was serving as a barrier to the intraocular, the positive vitreous pressure is gone. So the intraocular contents might be extruded if there is a very high positive vitreous pressure. Suture related complications, of course, sutures can be too tight, they can be too superficial, they can be irregular. You can take a full thickness suture or you can incarcerate the iris while taking a suture bite. And of course, expulsive choroidal hemorrhage, again because of increased vitreous pressure. Suture related problems. So look at this. This is a broken suture, right? Then this one's infected sutures. You see the little infiltrates on the suture? So these are infected sutures. They could also be sterile infiltrates. We will see how to differentiate between the two. Then look at this. You see this is cheese wiring because of very tight sutures with bulging of the corneal tissue in between. Then neovascularization accompanying the sutures. This is a premature sign of graft rejection, too much neovascularization. If neovascularization is there for more than 2 clock hours, it's going to lead to graft rejection more probably. And this papillary hyperplasia because of an exposed suture knot. This could happen. So these are suture related problems. Now, I mentioned immune suture infiltrates and infected sutures. So immune suture infiltrates. Now, these infiltrates you're not going to find in the button. These infiltrates are going to present only on the recipient side. You see these little dots? So they are often multiple, small, whereas infected suture infiltrates are solitary and larger. See, this is an infiltrate, right? This is an infiltrate. And you see the rest of the eye is also somewhat inflamed. Then immune related are going to happen only on the host side. This can happen on the host or the graft anywhere. These are not associated with epithelial defect, these infiltrates, and these are associated with epithelial defect. This would be unlikely to be associated with anterior uveitis, whereas infectious suture infiltrates will have severe anterior uveitis and ciliary injection and all that. Immune suture infiltrates, the treatment is steroids. Infected suture infiltrates, the steroids would be an absolute contraindication. You would treat them with antibiotics. Coming on to the post-op complications. So early means in the first 2 to 3 weeks. persistent epithelial defects. So the first sign of healing is that epithelial should grow onwards onto the transplanted button. So that usually should be complete within a week. If persistent, it would be persisting for more than 10 to 14 days. So that's persistent epithelial defects. Wound leak because of improper sutures. Loose or protruding sutures, we've already dealt with the suture related problems. Increased IOP can be because of the inflammation, because of pupillary block, anterior synechia, etc. Anterior uveitis, pupillary block. Increased IOP can also result from retained viscoelastic, which is more likely as a cause of increased IOP in the early postoperative period. Graft infection can happen. This is graft infection. And this one is an endophthalmitis, right? You see that the whole corneal button is infected and you cannot even see the glow, the red glow, the healthy red glow behind. And primary graft failure. Late postoperative complications include suture-induced astigmatism, which is 4 to 6 diopters on an average. So you can remove the sutures after 6 months only. That is when the graft host junction has healed completely. And you need to remove them only if causing an astigmatism of more than 3 diopters. So you can start removing the sutures, and once the sutures are removed, there may be some residual astigmatism that can be dealt with spectacles, rigid lenses, arcuate keratotomy, relaxing incisions, wedge resections, and even laser correction. Recurrence of original disease, such as herpes, can occur in the graft also. Wound dehiscence. Late wound dehiscence, yes, late wound dehiscence can also happen. Retrocorneal membrane formation. Now, the retrocorneal membrane can be composed of epithelial downgrowth. We know that healing involves the growth of the epithelium over the graft. So, epithelial downgrowth can happen from the junction. Fibrous ingrowth can happen from the stroma and the subepithelial tissue, that is fibrous ingrowth into the graft. For epithelial downgrowth, you have to remove the membrane. For fibrous ingrowth, you have to give steroids. For inflammatory membrane, also steroids. And retained descemet membrane or descemet detachment can also lead to a retrocorneal membrane formation. This would require removal of the descemet membrane. That is why you have to be very careful during the partial trephination also. You can use a swab stick or a Merosil sponge to check whether there is an overlying descemet membrane on the iris or not. And remember to always make sure to remove it. Glaucoma, a very common cause of graft failure. Rejection can be acute versus chronic. And Urey-Zavalia syndrome, I've already mentioned. So just a little bit about graft rejection and graft failure. So corneal graft rejection is when there is an initial period where the corneal edema subsides and the graft clears. But then there is a recurrence of blurry vision, redness, photophobia, pain, and so on and so forth. What are the risk factors? Age less than 40 years, more than 2 clock hours of vascularization, a large size graft, prior history of graft failure, prior history of glaucoma surgery, presence of anterior synechia, or pre-existing inflammation such as herpetic uveitis. The timing is very variable, occurring from days, that would be an acute rejection, to years, that would be a chronic rejection. So rejection can happen at any of the 3 levels, that is epithelial, stromal, or endothelial, and even subepithelial. So epithelial rejection is seen as an elevated ridge of abnormal epithelium in a quiet or very mildly inflamed eye and is usually self-resolving in nature. Subepithelial rejection is seen in the form of subepithelial dots, which are known as Krashmer dots, on the donor cornea with deeper edema and infiltrative, and it is basically a precursor of stromal rejection. Stromal rejection would be associated with a deeper haze, and endothelial rejection would have a linear pattern of keratic precipitates in this way. So here, the first one, this is the stromal haze that I'm talking about. This is a case of stromal rejection. Then this is the epithelial rejection. You see this very prominent line or ridge on the epithelium. These are the Krashmer spots, so subepithelial rejection. And this is endothelial edema. And there is a clear line here. This line is known as the Coda-Dost line and is a sign of endothelial rejection. So just a table summarizing all the 3 types of rejection. Remember, signs, symptoms, possible pain, photophobia, injection, decreased vision is going to be there in subepithelial, stromal, and endothelial. Epithelial is likely to be mild and self-resolving in nature. The treatment is topical corticosteroids. So as the level of the rejection increases, the level of rejection, by level of rejection, I mean the depth in the cornea, the frequency of the topical corticosteroids also goes on increasing. So epithelial might subside with 4 times steroid eye drops, whereas endothelial might require hourly steroids and even systemic or subconjunctival steroids. So the mainstay of treatment is corticosteroids in various forms. See, that's the mainstay of treatment. And remember to remove loose sutures. Loose sutures also trigger rejection. Lastly, we come to graft failure. So the difference between graft rejection and graft failure is important. Graft failure is defined as irreversible graft edema in the immediate postoperative period due to inadequate endothelial dysfunction. So in this case, the cornea never completely clears, right? It has been hazy from the start. Causes: unhealthy donor cornea, inadequate tissue preservation, and surgical trauma. How to prevent? Ensure that the donor endothelial count is more than 2000 in the specular microscopy. Storage time, ideally less than 7 days, is good. Preoperative IOP lowering, if required, you can give IV mannitol or oral acetazolamide to the patient. Intraoperative viscoelastic while suturing, yes, to avoid damage to the underlying intraocular structures, and proper handling of the corneal button. So that's about it. And thank you for your patient hearing. And you can go back and revise on my YouTube channel, My Opthal Teacher.